You know, okay, this is May. Now, the subject for today can be is the Dextroamphetamine, the Buprenorphine for stimulant use disorder. It's a case report, was taken from Harm Reduction Journal. We're facing a lot of what's called a twin epidemics between the opiate and the stimulants together in the US. Now we have some way to tackle the opiate use disorder with some medication. We're still struggling to tackle the stimulants. Usually patient comes to us with either with the suicidal ideations or with psychosis. I have no disclosure for this presentation. We're going to talk about introductions, about the stimulant, and about the case. We're going to go over briefly. The case is very long, so I made it just for half an hour. So we're going to talk briefly about the cocaine, how it works, the mechanism. We're going to talk about methamphetamine, the Dextroamphetamine, and also the brain insiders, the family mimics for the stimulants, the phenethylamine, the methylphenidramine. These we try to connect the dots to see if the Dextroamphetamine can replace these stimulants. We're going to present the case, and we're going to have some discussion, conclusion, and questions. So this case report was taken in British Columbia, Vancouver. This is very unique. This patient was taking a oral opiate agonist, and he failed. So he was switched to injectable opioid agonist treatment, which is popular in Vancouver, British Columbia. So this is the first report was presented, how successful was the Dextroamphetamine a reduction in use, not abstinence. What the goal was for the study is a reduction in use of the cocaine, not for abstinence. So it was holding very potential education and practical for the providers who treating the patients with the MATs and stimulant use disorder. So the current rising, that's what happened with this one. The current rise in the stimulant use disorder and opioid-related overdose among people who use opioids in recent years in the US have been referred to as twin epidemics. That's what we're dealing now. So what does stimulant use in general? That's the effect in general. It does increase the motor activity, the energy, the excitement, the euphoria. We're going to start with the cocaine. That's the cocaine, how it starts with the powder. How it works in the brain, it blocks the reuptake of the dopamine. It works in the limbic system, including the hippocampus, amygdala, thalamus, and hypothalamus. That's the transmitter neurons. That's the vesicles for the dopamine. These the cocaine, and this the receiving neuron. That's how the coke blocks the dopamine transporter. So you have enough dopamine, and the intensity of the effect when the dopamine is high. That's what happened with also the methamphetamine. So methamphetamine, that's how it looks to us. That's the unique in the methamphetamine different from the coke. The coke, when you take the coke, is 100% metabolized to cocaine and the benzoyl alcohol. This one, the methamphetamine, has a higher level of dopamine from the coke in two mechanisms. First one, it blocks the reuptake, and second, stimulate the release of the dopamine. Where it works in the nucleus accumbens, the ventral tegmental area, striatum, putamen, substantia nigra, and amygdala. This is a normal neuron with the vesicles for the dopamine, and this is a neuron affected with amphetamine. You see the increased release and block reuptake, so it has two effects. Now that the Dextroamphetamine, that's the tablets, and these are the capsules. The Dextroamphetamine brain works in three different mechanisms. It mimics the cocaine by reuptake, block reuptake, mimics the methamphetamine by also block reuptake and stimulate the release, and also mimics the family of the amphetamine in the brain, which is phenethylamine, and the methylphenidramine, which is a derivative of the phenethylamine, and which is also a neurotransmitter and amphetamine-like product in the brain. These have the chemical formula of the Dextroamphetamine. The duration, that's we're talking about the medications, the immediate release, usually 4 to 6 hours. extend 8 to 12, sometimes 15. The elimination on the children is low, 9 hours, and the D isomer, 11 hours for the L isomer. Adolescents different, the D 11 and the L 13 to 14, adult 10 hours, and the L 13. That's the 2 isomers for the dextroamphetamine. The immediate release, usually it peaks in 3 hours, where the extended release in 7 hours. Phenethylamine, as I stated, is a neurotransmitter and also a stimulant in the human brain. And also, that's why we mentioned a neurotransmitter. That's the phenethylamine chemical formula. This is the N-methylphenethylamine, which is derived from the phenethylamine. And usually it's a amphetamine, isomer of amphetamine produced in the human body. And usually it has been detected less than 1 microgram over 24 hours. That's how methylphenethylamine mimics also the dextroamphetamine. That's the case we have studied. It's a 51-year-old male diagnosed with opioid and stimulant use disorder, was receiving injectable opioid agonist treatment with hydromorphone 50 milligram ml solution at a community clinic in Vancouver, Canada. Prior to receiving IOAT, he reported injecting illicit opioids and smoking crack cocaine daily for over 2 decades and had multiple prior oral IOAT attempts. He was prescribed 200 milligram of hydromorphone 3 times per day, 600 milligram total per day, since August 2014 with dose adjustment. He had tried acetaminophen, which is a pharmaceutical grade heroin, in February 2015, but preferred hydromorphone. Hydromorphone supported him to stop his illicit opioid injection. However, he reported ongoing daily crack cocaine smoking on average 10 to 15 rocks per day. His medical history included numerous conditions that were aggravated by smoke crack cocaine, including diagnosis of hepatitis C, chronic obstructive pulmonary disease, and pulmonary hypertension. He developed pulmonary embolism as a result of deep vein thrombosis moving to his legs. The clot damaged the veins of both legs, and he developed associated chronic leg wounds. The ongoing use of crack cocaine contributed to poor wound healing. He reported ongoing drug dealing daily to support his use. He was motivated to reduce his crack cocaine use in order to, number 1, limit spending on cocaine and longer-term goal of saving money. Number 2, minimize his physical health burden. He reported that crack cocaine use helped him in remaining alert to accomplish daily tasks, such as found it difficult to cut down on his crack cocaine. He presented to his routine physician with the goal of reducing his cocaine use and was prescribed dextroamphetamine for the treatment of a stimulant use disorder. Prescribing dextroamphetamine began in January 2014-2020 at 15 milligram twice daily, though the patient was advised to begin 1 capsule and could increase to 2 if the dose was tolerated, with no mild side effect. On February 1st, the patient reported tolerating 15 milligram dextroamphetamine twice per day and did not report experiencing any side effects, including sleep problem, agitation, change in appetite. He reported that his crack cocaine craving were reduced but not eliminated. The patient and physician decided together to increase the dosage, and the prescription for dextroamphetamine 30 milligram twice per day was written. The clinic's dosing protocol allowed dosing up to 120 milligram per day in order to meet patient preferences. In February 23rd, 4 weeks after beginning prescription, he reported less craving, clinically significant reduction in use from 10 to 15 rocks daily to between 1 to 2 rocks on average 2 days per week. He reported having stopped his daily drug dealing as it was no longer required to support his crack cocaine use. He was meeting his self-identified therapeutic goals of reducing his crack cocaine and reducing his spending crack cocaine. The patient reported that dextroamphetamine helped him to feel energized, feeling that he had previously been seeking from crack cocaine. Clinical improvement were witnessed in his abscesses and chronic wounds, which began to heal. In addition, care providers noted that he became more cognitively alert and was engaged and interested in conversations. In May 18, 2020, the patient discontinued the medication, stating it was no longer required to maintain the reduction in cocaine use he had attained. Upon the most recent clinical visit on October 5, 2020, the patient reported having maintained significant reduction in cocaine use, and the prescribed physician reported persistent improvement in patient's physical health, cognition, and social functioning. For example, the patient maintained his reduction in crack cocaine, experienced persistent improvement in mobility, reduced edema in the legs. He was achieving his therapeutic goals of cocaine, reduced cocaine use, and decrease in spending while receiving dextroamphetamine. In the recent study following the shared decision-making, the patient and the prescriber, dextroamphetamine was prescribed with the objective of supporting reduction and not abstinence from cocaine use. In the present case, the benefit of reducing cocaine extended, for example, the reducing engagement in drug dealing and spending less on cocaine. Urine drug screen to detect the presence of cocaine metabolite were not conducted and would not have captured the clinical significant reduction in his cocaine use the patient reported after decades of regular daily use. The improvement measured not with UDS, with cocaine craving, self-reported number of days of cocaine use, physical and psychological health, and social functioning. Clinical trial, the dextroamphetamine in the MET clinic reported data that all adverse events, sleeping problem, agitation, irritability, gastrointestinal problems, change in appetite, weight, dizziness, and craving. Sleeping problems were found to be the most commonly reported adverse events, reported by approximately 1/3 of the patient in the dextroamphetamine group. Heart rate, blood pressure, and body weight were monitored throughout the trial, while heart rate was found to increase from baseline in 12 weeks among people receiving dextroamphetamine. EKG data revealed no abnormality and no serious adverse events were observed. They found only unpleasant sensation, which was usually vague and difficult to define. They could not find and pinpoint physical signs or symptoms. And after they stopped, they discontinued the medication, the adverse effects resolved quickly. For example, among patients receiving injectable heroin, the Dutch trial, randomized control, conducted that dextroamphetamine was safe, effective for treatment of cocaine dependence, with significant reduction in urine positive for cocaine metabolites, self-reported craving day and days of cocaine use. Secondary analysis found treatment with dextroamphetamine supported significant improvement in health and social functioning, given the major public health concern, untreated psychostimulant use disorder, and the lack accepted pharmacological treatment. A number of studies demonstrated promising evidence for dextroamphetamine treatment stimulant disorder. For example, a randomized clinical trial in Australia found significant reduction in cocaine positive urine sample, self-reported craving, criminal activity, and severity of cocaine dependence in the dextroamphetamine arm, but not in the placebo arm. A randomized clinical trial conducted among methadone patients in the US found that patients receiving 30 to 60 milligrams of dextroamphetamine had significant reduction in cocaine use compared to those receiving lower dose or placebo. Dextroamphetamine can be prescribed for any patient with, to support patients with stimulant use disorder to reduce or stop cocaine use. This case was demonstrated that dextroamphetamine was prescribed with significant reduction in cocaine and was experienced among patients that had been regularly using cocaine on a daily basis for many years. Settings where patients that regular contact, usually these patients in regular contact with the MET clinics, which serve as suitable location to integrate the dextroamphetamine, prescribing for patients with illicit stimulant use disorder together at the same time with the and associated harms. Further, beyond the dextroamphetamine, they found that you can use also methylphenidate because it's act exactly like the methamphetamine by block reuptake of cocaine, of the dopamine, and stimulate. So they found it also successful treatment with the methylphenidate. They found that with the ADHD, that the mixed salt, the D and the L, the dextroamphetamine, amphetamine is more successful with patients with ADHD using stimulants. A recent systemic review further suggests that dextroamphetamine and methylphenidate show the promise for treatment stimulant use disorder for people who use methamphetamine, in addition to the cocaine. Dextroamphetamine, the study was in addiction to usually why we found that dextroamphetamine is successful for this treatment. First of all, it blocks, as we stated, it blocks the reuptake of dopamine and stimulate. Second, also because it shares the inside amphetamine in the brain, the phenethylamine and the methylphenidate. And lastly, also, with the dextroamphetamine, the D-amphetamine, it has significant potent agonists at the TAR1 receptor, which regulate the dopaminergic neurotransmission than the L-amphetamine. These findings could explain the stronger reinforcing effect of the D-isomer than the L-isomer with the dextroamphetamine. Thank you, everyone.
Thank you so much, Dr. Algeri. I know that was your first ECHO presentation, so I wanted to just give you a big shout out. That was wonderful.
Yeah.
Anyone with any questions, comments, or thoughts, feel free to unmute. I'm also happy to read it out loud if you prefer to chat it in. But yeah, thank you so much, Dr. Algeri.
Thank you.
Dr. Algeri, quick question. Can you show us the slide this patient was on? I know he was on basically diacetylmorphine and also hydromorphine injection. And this is a very weird, like, and actually the guy who runs this clinic came to us years ago and gave us a presentation. This is what they're doing in Vancouver. I understand this basically patients receive the injectable. Heroin. Basically, it's industrial heroin for MAT. So can you show that slide? I just want to see the dose. I was surprised to see
the dose. Yeah,
hydromorphine dose. So I'm trying to correlate.
This is the
equivalency.
200, 3 times.
300 is it? Was
200.
200 milligram hydromorphine IV.
Yeah.
I mean, injectable, not IV.
Injectable.
So that is. I just checked the equivalency table. We're talking about hydromorphine here, opioid equivalency. We're talking about parenteral is basically is 1.5 is equivalent to 0.3. That means 5 times. Yeah. So somebody's receiving hydromorphine 200 milligrams injectable. It's almost like a 40 milligram of buprenorphine a day. Is that right? That's this is a heavy. This is definitely they're giving this patient a lot of opioids every day to maintain to maintain his abstinence from street drugs. So the quick question is, like, I'm surprised to see. I don't know a rock of cocaine how much how much cocaine it is. But my question is basically this dose of, like, we're talking about pharmaceutical dextroamphetamine. This is just a 30 milligram and even like 60 milligram a day, and that can keep him from using street cocaine. That is amazing. This case, I think, it's really a case worth discussion.
Yeah, because usually also the methamphetamine, usually when you take the amphetamine, also 40% only metabolized by the 2D6 to amphetamine, the L-amphetamine. The 60% does not metabolize, change and changed. That's the powerful of the methamphetamine, and change, and it's excreted and secreted from the kidney. That's why the kidney is so damaged. So large percentage of methamphetamine does not metabolize, about 60% change. That's the psychosis is very bad, and that's what other side effects from it.
I was just going to say, it's my understanding that the problem with using stimulants for, like an agonist treatment, stimulants for stimulant use disorder, is that it does reduce cravings, but it doesn't stop use. That patients continue, like the double-blind studies that have been done have shown that people continue to use.
They continue to use. Yeah, wasn't the study for the abstinence just to reduce the comorbidity as the harm reduction? The harm reductions other than using coke with the adverse effects with the comorbidities of the HIV and the hepatitis, the endocarditis, the infection stimulant. That's why it wasn't for the abstinence, it was for harm reduction.
I think one of the limitations too is a lot of those studies use normal dosing of stimulants. So what we're used to for ADHD, and the idea being that, when somebody's injecting a gram of methamphetamines compared to taking 30 to 60, maybe max of Adderall, mixed amphetamine salts, I mean, it's not the same thing. So if we are going to start using this as a form of MAT, we're probably going to have to get used to using higher doses than we're used to for both ADHD and narcolepsy. So it's kind of an interesting to think about.
Yeah, wasn't, you see, if you can see that wasn't the goal for the abstinence was the harm reduction. That's what it was allowed to go to 120, but they did not go to 120, they kept it at 60 with the reduction. I think, yeah, if the dosage increases to help better for him.
I mean, for my money, I think the reason they use Dexedrine largely is because just how it's cheaper than some of the other forms of amphetamines, legal amphetamines. From a pure, I don't know, is our pharmacy expert on with us today? I didn't notice. And but from a pure standpoint, if you're thinking harm reduction, I would think that something like Vyvanse would be the ideal stimulant to use. The unfortunate thing is just the cost of Vyvanse. And the reality that pharmaceutical companies are not going to pursue this indication because it doesn't even exist. So you have to think like right now we're basically in the 1960s and there's no methadone, there's no Suboxone, there's not naltrexone for this. So whoever's going to start doing this, it is going to be at the forefront, and somebody, kind of have the gumption and the guts to go out and do this and somehow make it a thing. But I think eventually this is where the treatment of stimulant use disorder is going to go, is by replacing it.
Yeah, but I noticed there is something called the DMET, the Desoxin.
Yeah.
The Desoxin, the 5 milligram, it's a black box, but it has a black box with the potential abuse.
Mm-hmm.
This one.
Yeah, it's definitely Dexedrine is an interesting one, but some of the other ones might be a little bit safer. It's just the cost and the reality that the pharmaceuticals are not going to pursue this. They're not going to start a study because they already make plenty of money from treating ADHD. So why treat folks with stimulant abuse problems?
You're right, Jeremy. Actually, the clinical studies, most of the studies for stimulant use in this part, for methamphetamine or cocaine use disorder treatment, mainly is Vyvanse because it's a low potential for abuse and different other reasons. Yeah.
I think mostly the D is more abused because they found that from the animal trial they have self-administered the D, not the L. So the D is more abusive and than the L. That's why it's using it.
Just that from my experience, it's a lot easier to get the Ritalin approved. I haven't had any trouble with that.
Because of the methylphenidate, that works as the same thing as the other one. I agree.
Another thing to think about is it possible to saturate dopamine receptors? Kind of the model of methadone is to create a blocking dose where you saturated the receptors and then somebody doesn't feel any additional intoxication because the receptors are saturated if they use something. And I don't know if that's a possibility with dopamine. Dopamine is all over the brain, and I'm not sure, what the answer is to that, if that's a possibility.
The other idea is if you were able to come up with a partial agonist for dopamine, so like a buprenorphine type. I don't know if there are any that exist in nature actually, but it'd be, I guess Abilify might be the closest thing to a D2 partial agonist, but the concern is with things like aripiprazole, Abilify can actually lead to increased rates of substance use. Yeah, so it's a very tricky idea. Is if you blast somebody with so many dopamine agonists, I mean, they are likely to do other things. So it's this high wire act. Whereas with opioids, you're not necessarily worried about that. Plus, there's always a concern of psychosis, which you mentioned methylphenidate, less likely, very kind of similar methylphenidate, Ritalin, similar mechanism of action to cocaine. So very similar. Cocaine usually doesn't make you psychotic, whereas methamphetamines, the dual action is, so much more profound and powerful. So.
Yeah, and the length of the effect with cocaine is so short, especially crack cocaine. So here's somebody who's been, chasing that first high, smoking 20 rocks a day. And so it makes sense that he would have really low energy with that. So, really interesting case. Once again, I think there's a huge difference between cocaine and, methamphetamine, just in terms of intensity and duration of action. So I don't know, I haven't noticed our methamphetamine users saying they have low energy. I don't know if you guys have seen that.
Just when they try to cut back on it, they get washed out pretty quick.
Well, thank you all so much. This has been wonderful discussion. Were there any other, Dr.
Yeah.
Floria?
I just want to make an observation and a comment. So I've generally stayed away from stimulants for folks with stimulant use disorder, just because the literature has been pretty muddy over the years, and I haven't really seen terribly convincing evidence. However, the most recent kind of meth, a wave sweeping across the United States, is making it harder and harder to stay away from it. And as many of you know, there's a new way of making meth. They don't use the stuff that blows up anymore, the flammable solvents, and they can basically, they don't need ephedrine and Sudafed. So you can go back to the store and get your sinus medication, hopefully in the near future. But that means they can produce vast quantities at very low cost and just flood the market. So my willingness and our ability to say, stimulants, maybe, maybe not, I feel like is lessening as the pressure to be able to treat stimulant use disorder along with opioid use disorder. So I have a couple of folks that have opioid use disorder and ADHD who are doing very well on stimulants as well as Suboxone and have stopped their stimulant use, but it's not a controlled study. It's a very small N. But I think the pressure as meth sweeps, it's a little more of a West Coast phenomenon than East Coast, and as it sweeps to the East Coast, I think we're going to be more and more pressure to find more effective treatments for stimulant use disorder. So just kind of my 2 cents on it.
I think the place for stimulants, it's a hard ask to say somebody's strictly doing stimulants to offer them a pure stimulant for treatment. However, if somebody truly has ADHD along with stimulant use disorder, along with maybe an opioid use disorder or whatever, but I would say that group of people definitely, I feel like it's appropriate to use a stimulant if you do it correctly. Because again, if somebody has raging ADHD, which people do, I mean, everybody says they could concentrate more and everything, but when you treat ADHD patients. So if somebody has true ADHD and you're not treating it, they are more likely to do impulsive things and use drugs and get in trouble. Would you rather they be using a street drug or something that you can control and monitor? And in the case of if you do use methylphenidates or Ritalins, it should not show up on a drug screen. So if they are testing positive for amphetamines, then you know that they're using on top of it. Or, a regular amphetamine will not show as methamphetamine. So there are ways to monitor it. It's a little bit trickier, and you might have to send off for labs and such. But I think that is a good place to start if you have true ADHD patients, because again, trying to convince them that Strattera is going to work or Wellbutrin maybe or something like that, it might help a little bit, but the reality is it's
stimulants.
it's not going to be nearly as powerful as using grams of amphetamines a day. And if you can get by using that, I mean, think of how much less toxic it is on the brain to, again, 60 milligrams of Adderall compared to a gram or 2 of methamphetamines daily. I mean, a month's supply of prescribed medicines per day that they're using. So it's interesting.
Safer for them.
Any other, Dr. Houston? Sorry, I keep cutting you all off.
Oh, you're good. I was just going to say, from a peer perspective, it's interesting, but you know, if you look at what is actually abuse, so stimulants are considered category 2. They've done polls. The reality is, like, prescribed stimulants are not all that abused as much as people think. It's a small percentage. Like the rates of benzo abuse and opioid abuse are actually higher than stimulants. So most people that are prescribed stimulants take them appropriately. And certainly what I've seen in practice is, this is one last thing, is that especially teenagers who are doing well on stimulants, and then their parents get scared and they take them off stimulants. And then what invariably happens is a lot of them go and start using stimulants on the streets. And this happened to somebody recently on the DDU, but they started using stimulants and their life became untenable, and they're using and using. And then the thing that actually helped this guy was putting him back on a stimulant prescribed, because now he's not using it. And get him back into treatment and treat what we know he's had since he was a kid, is ADHD. So don't be afraid to do it so much. And you know, you talk about forming alliances with patients. I mean, having that amount of trust that you're willing to prescribe them a stimulant, you can really get them to buy into your treatment sometimes. So be careful, but you know, you can really help people.
A great point. Thank you for adding that, Dr. Husted. Any other comments from the group or questions or thoughts you want to share? All right, well, if there are questions after, oh, Dr. Aldre, did you want to mention something?
No, thank you, everyone.
Sure, absolutely. No, thank you so much. We really do appreciate you taking the time and sharing that with everyone. And if anyone has questions after the session, just email me and I'll send it to Dr. Aldre to have addressed. The only announcement that I have is that our next session will be on April 11th, and Laura Lander will be discussing therapeutic and behavioral treatments. Keep an eye out for that reminder, and we'll see you all next time. Thank you, guys.
Thanks.
Take care.
Thank you.